Testing. Testing. Good morning. Could I ask all our guests to please take their seats? Good morning. Distinguished guests, ladies and gentlemen, it's my greatest pleasure to welcome you all to the third day and the final day of الحياة First International Fertility Conference. I am Dr. Muad Abu Daber and I'll be your moderator for today. We all look forward to our guests' speeches and valuable scientific discussions covering a broad spectrum of topics. We're excited to start our first session covering the topics in the field of reproductive surgery. I'd also like to welcome our session chairman, Professor Abdul Hafid Abu Dhair, Professor Muhammad Abu Dabbous, Professor Abu Bakr al-Nashar. Could you all please join me to the stage? We will now start our first session for today. I would like to remind that all speakers are required to strictly adhere to their time limits, as previously illustrated in the conference booklet. Each speaker has his time limit pre-specified in the conference booklet. The chairman will assist me in moderating and managing the time sessions. Our first keynote speaker for today is Professor Yusuf Gadmour from Libya. He is a professor at the University of Tripoli. He has completed his higher education in the UK and Ireland. He's currently the head of the Gadmour Center for Infertility. He has extensive experience in therapeutic hysteroscopy. He'll be talking about hysteroscopic uterine septum resection to improve reproductive outcomes, report of 2 cases and review of the literature. Could you please join me to the stage?
السلام عليكم ورحمة الله. تمنياتي للجميع بالتوفيق ولهالمؤتمر النجاح إن شاء الله تعالى. Hysteroscopic uterine septum resection to improve reproductive outcome. Introduction. As you know, uterine septum results from incomplete resorption of the fused medial wall of paramesomorphic duct, Mullerian duct. It has been reported that the incidence of uterine anomaly range between 0.2 to 2.3 of the women. Septate uterus is the most common uterine anomaly, accounting for 35% of these anomalies. septate uterus is associated with infertility and adverse pregnancy outcome, including miscarriage and preterm birth. For some explanation of the septate and bicornuate and the normal, you know if the depth is less than 1 centimeter and the angle is more than 90 degrees, this is, we call it normal or arcuate uterus. But if the depth is more than 1.5 centimeter and the angle is less than 90 degrees, this is a septate uterus. If it is bicornuate, as you see, the depth inclination is more than 1 centimeter. So it's very important to know these to diagnose the septate uterus. The diagnosis usually done by many methods. One, vaginal ultrasound scan. This is need experienced doctor to diagnose the septate uterus. Also, 3D ultrasound scan can help and can give you correct diagnosis. Of course, hysterosalpingography also give you a clue that it is a septate uterus. MRI, and of course, the hysteroscopy, you can see by your eyes the septate uterus. I will review the previous studies on septum resection and reproductive outcome. How many studies and what's the outcome of septum resection on reproductive outcome. As you know, the debate is still going on the outcome of uterine septum resection on fertile women, and especially on patients with miscarriage. I will review the literature of studying the effectiveness of the septum resection on pregnancy rate, live birth rate, spontaneous abortion rate, and preterm labor was done. There are many papers studying this topic. I will review some topics and papers before. The first one, it is large cohort study. Studying is 689 patients have uterine septum and they have miscarriage. They found the miscarriage rate is about 41%, decreased to 12% post-resection. The second study, it is a prospective study, also about 800 cases, and they look for preterm labor and malpresentation and growth restriction. And they found that preterm labor is 35%, decreased to 7.2 post-resection. The paper number 3, it is a systemic review about uterine septum, 1,587, and they have recurrent miscarriage and primary and secondary subfertility and preterm delivery. They said the pregnancy rate 60% and live birth rate is 45%. This is a retrospective study, small amount of patients, it is 100, about 100, and they look for primary subfertility, and they say the pregnancy rate 43.1%, and live birth rate is 35%. The next is observational retrospective study. It is 128 uterine septum, primary subfertility, and recurrent abortion. Pregnancy rate after septum resection is 60%. Live birth rate is 54%. So most of them, they are not randomized control study. And there is a good study I will show you now. This is prospective study, 257, uterine septum, primary subfertility, and recurrent abortion, preterm labor. Pregnancy rate 35%, live birth rate 35%. There is good study done by this doctor and presented in the ISHRI 2021, and it is systemic review and meta-analysis. This study they take about 58 articles were pre-selected based on title and abstract. The endpoint were evaluated in 3 subgroups. So they divided these 58 articles in 3 groups, 3 subgroups. Group A, 10 study, and they control between the septate, or they may see the difference between septate and the control. The group B, 8 study, they compare removed septum with unremoved septum. The group C, 19 study, and they compare before and after removal of the septate uterus. In the group A, which is, they compare just the normal uterus with septate uterus. They found a lower pregnancy rate and live birth rate in the septate uterus, and it is significant. And they find higher spontaneous abortion rate and preterm labor rate. And also it is B less than 0.000. So the difference between the septate and the control shows that the septate uterus has lower pregnancy rate, lower live birth rate, and higher spontaneous abortion and preterm labor. The group B, which include 8 studies, which is comparing patient had operation and removed the septum, and patient does not remove the septum. They find the pregnancy rate and preterm labor not different, but they found the lower proportion of spontaneous abortion in cases who removed their septum. Group C, which is including 19 studies, before and after removal of the septate, live birth rate was higher with removed septum. And it is significant also. Spontaneous abortion and preterm labor was lower with removed septum. So the result of this meta-analysis confirmed the detrimental effect of uterine septum on pregnancy rate, live birth rate, spontaneous abortion, and preterm labor. Its treatment seems to reduce the rate of spontaneous abortion. So this is confirmed by the 3 groups of the study that if you remove the septum, the rate of spontaneous abortion will be lower. Metroplasty should still be considered as a good clinical practice in patients with history of infertility and recurrent abortion. I have two case reports I would like to show you in the same topic. I have one case, 20 years old woman. She's para 1 plus 6 abortion. Complaining of recurrent miscarriage for 5 years. The miscarriage were between 7 to 10 weeks. And no one done for her hysterosalpingography at all. She has hyperprolactinemia, and I controlled with Dostanix. Semen analysis was normal. 3D ultrasound showed uterus normal size with large septum, not reach the cervix. Hysterosalpingography, I done it, and it shows the cavity large, septum, both tubes patent. I did laparoscopy and hysteroscopy in the same time to see the fundus, is there dimple or not, so I can know how much I go for this septum resection. And then I did the hysteroscopy. I did resection with the resectoscope, and then I insert IUCD for 2 months. After 2 months, I did second look, remove the IUCD, and I cut the remnant with the resectoscope. After 4 months, the patient got pregnant, and now actually she's, I did cesarean section for her last week, and she delivered a boy. This is her video. Could you, I will use it here. This is the ultrasound. This is the large septum. I start cutting with the resectoscope. Putting IUCD, there is controversial. Some put, I was putting IUCD, and nowadays I am not using IUCD, and the result, it is the same. لا الصب اللي واحدة فيه. Go back to the slides. The second case, it is an interesting case also. She's a 31 years old woman complaining of primary infertility for 7 years. Hormonal assay of the wife was normal. Semen analysis was normal. And then when I did speculum examination, I see large vaginal septum. And also I can see 2 cervix, not 1 cervix. Vaginal ultrasound scan, I see large septum with 2 endometrium. I did laparoscopy and hysteroscopy for her. Laparoscopy fundus uterus looks normal. Hysteroscopy, I did resection of the vaginal septum, and then I cut the cervical and uterine septum with the resectoscope, and also I insert IUCD for 2 months. I did second look after 2 months, and I removed the resection of the remnant of the septum by resectoscope. Patient got pregnant, and she is now pregnant. This is the video. This is the vaginal septum. I cut it with the cautery, and then I went inside with the resectoscope. I cut the بقية الvaginal septum, and then I will cut the septum between two cervix. I change to this loop. You have to close the vagina so the fluid will not go out. This is after the second look. There is some remnant of the uterine septum. I did the second operation and I cut the remnant of the uterine septum. Okay, go back to the slides. So my conclusion, number one, hysteroscopic septum resection is associated with an increased live birth rate and reduced miscarriage rate in patients with recurrent miscarriage and primary infertility. Primary infertility and recurrent miscarriage, cutting the septum has a good result. The effectiveness of septum resection remains unclear for patients with secondary subfertility. Number three, there is limited evidence to demonstrate that hysteroscopic septum resection significantly improve the rate of pregnancy and live birth rate in women undergoing IVF. This point, I think, if IVF is failed, maybe hysteroscopy is must. Maybe you will find the polyp or something else as a cause of failure of the IVF. Thank you very much.